Good afternoon. My name is Dr. Sachin Gupta. I'm the Scientific Director at ASCP, and I'm the moderator of today's webinar, which is entitled Prognostic Diagnostic Excellence by Improving the Communication of Urgent and Unexpected Diagnosis in Anatomic Pathology. Here are some housekeeping items. The presentation is being recorded, and by participating in this recorded video conference, you agree that ASCP may use the recording of your image or statements at ASCP website. Please do not share any PHI or PII information or any information about the patients. CME or CMLE credit is available for this event. Instructions for claiming credit will be shared at the end of the presentation, and it will also be sent to your email address, which you provided at the time of registration. The downloadable slide set will be available at the end of this event, and a link of the slides will be shared via the chat at the end of the presentation. And also, at any time you have a question in your mind, please feel free to type your questions in Q&A section, which you see at the bottom of your screen. We will address these questions with our presenters at the end of the presentation. So we have two fantastic presenters today for this interesting topic. Our first presenter is Dr. Varsha Manucha. Dr. Manucha is a professor of pathology at the University of Mississippi Medical Center. And our second presenter is Dr. Govind Bhagat. Dr. Bhagat is the professor of pathology and cell biology at Columbia University Irving Medical Center. The faculty disclosures can be viewed on your screen. I would like to mention and thank Gordon and Betty Moore Foundation for funding this program and this project. And this program is administered by the CMSS, which is the Council of Medical Specialty Societies. So the learning objectives of today's webinar are: define urgent and significant unexpected diagnosis, discuss current guidelines and practices for the communication of these findings. Our presenters will discuss high priority communication barriers around the communication of these findings. Our group will discuss the best practices and recommendations for effective and timely communication of urgent and significant unexpected diagnosis. And also, the presenters will also discuss the quality assurance methods to make sure how to trace or track these findings or these diagnoses. So the objective of this program is to promote the role of pathologists and lab professionals in advancing diagnostic excellence along the diagnosis to treatment trajectory. So just to give you a little bit background about this topic, the Gordon and Betty Moore Foundation created the term diagnostic excellence to imagine a world in which the diagnosis was ideal. The diagnostic excellence requires that the process is optimal and an accurate and precise diagnosis is rendered about the patient health conditions. Diagnostic excellence embraces 6 dimensions of healthcare quality, which demonstrates that the care should be safe, effective, patient-centered, timely, efficient, and equitable. So the quest for the diagnostic excellence today encounters many obstacles, including diagnostic error. So according to the National Academy of Medicine report, which you see on your screen, diagnostic error is the failure to establish a timely and accurate explanation of the patient health problem or communicate that explanation to the patient. Interesting finding is that most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequence. In context to the pathology, a diagnostic error could be like this. This is just one example. Let's say a pathologist finds an unexpected finding in anatomic pathology specimen. Pathologist tried to communicate that finding to the treating clinician. And let's say treating clinician is not reachable in this case. That will delay the communication, right? So that will delay that reporting of the critical diagnosis which further delays the patient treatment. So that could be one scenario of the diagnostic error in the anatomic pathology. So not only that, there are still some unanswered questions like, for example, what are urgent and significant unexpected diagnoses in anatomic pathology? Are all unexpected diagnoses urgent? Why the notification and documentation of the communication is so important? And how should these findings be communicated in an effective and timely manner? So to address these questions, we at ASCP, we created a learning collaborative group, which consists of pathologists from different practice settings serving diverse patient populations. So the group participated in various meetings to discuss these current practices and barriers to communicate urgent and significant unexpected findings. The group facilitated discussions and in-meeting polls. And then the group actually proposed and came up with these best practices and recommendations for effective communication of urgent and unexpected diagnosis, which actually our presenters are gonna talk about today. So before I move on to our presenters, I just wanted to in a meeting poll just to understand the demographics of our participants and to understand the intensity of the problem. So the first poll question is, what is your primary healthcare role? Pathologist, lab medical director, administrator, technical lab director, operations manager / director, or other. 57% of our participants are pathologist or lab medical director. 12% are administrator, technical lab director / operation manager director, and 31% of our participants answered other. Okay. Do you currently notify the clinicians of urgent or significant unexpected diagnosis in anatomic pathology? Okay. 86% said yes, they currently notify clinicians of urgent and significant unexpected diagnosis in AP, whereas 14% said no. Okay, that's very nice. Poll number 3. Do you understand the distinction between urgent and significant unexpected diagnosis in anatomic pathology? 72%, that's very interesting. They do understand that the distinction between urgent and significant unexpected diagnosis in anatomic pathology, whereas 28%, they do not understand the distinction between urgent and significant unexpected diagnosis in anatomic pathology. This will definitely help our presenters to, when they're presenting this to our audience today. Poll number 4. Do you experience any barriers in communicating urgent and significant unexpected diagnosis in anatomic pathology? This is a loaded question, but try to see, do you experience any communication barriers? Yes or no? Okay, let's see, 80%. So definitely it's a problem. It is a problem right now where our pathologists and lab professionals do experience the barrier in the communication. So thank you so much for answering these questions. So let's move on to the next slide. And with that, let me introduce Dr. Manucha. Dr. Manucha, as I mentioned, she's a professor of pathology at University of Mississippi Medical Center, Jackson. So Dr. Manucha, take it away.
Thank you very much, Dr. Gupta, for this introduction and the comprehensive overview of the topic. And thank you, ASCP, for inviting me to be a panelist in this extremely important topic. I'm really happy to see that majority of the people are actually pathologists who have signed in, but also there are a lot of administrators. In the next 15 minutes, I'm going to talk about the evolution of critical value in anatomic pathology and the current status and the challenges that we face in actually applying it in real life. The concept of critical value was actually came up in 1972 by Dr. George Lundberg, and he described it as a laboratory value associated with a life-threatening condition that requires immediate attention and hence immediate notification to the providers. The concept was readily accepted, and it was found that the implementation of this system significantly improved patient outcome. It was soon endorsed and incorporated into various regulatory guidelines. The goal of all these guidelines was that it should improve the effectiveness of communication amongst caregivers. The practice of notifying physicians of critical values, as we know, is a standard of practice in clinical pathology, and there are robust guidelines on how a pathologist should handle that. However, there are no comparable guidelines in anatomic pathology, and at least at that time when we were working, when the members of Association of Directors of Anatomic and Surgical Pathology were looking at this, they found that there were no robust guidelines to guide the pathologist in using this concept in anatomic pathology. So they got together and they ran a survey to evaluate the opinion of the members of ADASP. And they found that while most of the members agreed with the concept of critical diagnosis in anatomic pathology, they found that majority of them did not agree on what constituted critical diagnosis. There was agreement only on a couple of them, and those were completely unexpected malignancies, malignancies in critical sites, and presence of infectious organisms in immunocompromised patients. The survey also highlighted the challenges in implementation of critical value in anatomic pathology. Firstly, in clinical pathology, critical value is a numerical value, and it is the burden of notification is mostly on the medical technologist. In contrast, in anatomic pathology, a critical diagnosis is usually descriptive and can be very wordy. And I'm sure majority of you feel it is best way to actually communicate it to the provider is through verbal discussion. Also, the diagnosis, and in many instances, the diagnosis in anatomic pathology are actionable and maybe ultimately fatal, but they do not pose any imminent threat to life. The current guideline is that when there is a critical value in clinical pathology, it should be notified to the physician within 30 minutes, at most within 40 minutes. However, that is absolutely not possible in anatomic pathology because after adequate fixation, the tissue processing at least takes 24 hours. So it is not practical to do that in anatomic pathology. And also, as we will see in a lot of surveys, there is no agreement on what constitutes critical or urgent in anatomic pathology. Also, literature has shown that lapse in communication is more likely to cause harm rather than a brief delay in anatomic pathology. And therefore, the conclusion is that the emphasis in anatomic pathology should be on effective and timely communication rather than rapid communication. There was also a consensus that critical value is not an appropriate terminology to be used in anatomic pathology. And that is because using the critical value as such, the way we use it in clinical pathology, will raise inappropriate expectations amongst clinical teams and regulators, such as Medicare, Medicaid, and state health departments, expecting the same urgency in communication as in clinical pathology. This expectation of communicating critical diagnosis in anatomic pathology 24 hours a day, 7 days a week is going to create unnecessary burden on resources and stress on pathologists who will end up spending a lot of time and effort in communicating a diagnosis that may be significant, but actually not life-threatening. Additionally, it will also result in development of unrealistic medical legal standards of practices. Therefore, it was thought that there should be alternative ways of describing this in anatomic pathology, and suggestions were using critical results, critical diagnosis, urgent, significant, unexpected diagnosis, which actually received the most consensus. So to determine the policies and the current practices in utilizing this communication of significant and unexpected critical diagnosis in surgical pathology, College of American Pathologists surveyed about greater than 1,000 laboratories. These were already participating in their performance improvement programs. And they found that at least 25% of the laboratories actually did not have any policy at that time regarding the communication of critical diagnosis. And of the 75% that had a policy, 30% had a general policy without any specific examples. And most pathologists preferred that the determination of critical diagnosis should be left to their own judgment and discretion. So recognizing the difficulty in applying the concept of critical value in anatomic pathology, the College of American Pathologists and the Association of Directors of Anatomic and Surgical Pathology formed an expert panel who reviewed the literature that was actually available at that time and came up with general guidelines to help pathologists. They defined urgent diagnosis as clinical condition that should be addressed as soon as possible. And this includes examples such as an infectious organism in an immunocompromised host or an unexpected malignancy. Similarly, they actually defined significant and unexpected diagnosis as a clinically unusual, unforeseen, and unanticipated medical condition that should be addressed at some point in patient's clinical course. The panel also proposed 6 broad guidelines, and the first of it was that each institution should create its own policy, which should be discrete and separate from the policy that relates to the notification of critical values in clinical pathology. Secondly, each department in collaboration with clinical staff should develop a list of urgent diagnoses. And this should include life-threatening infections that I just, for example, mentioned, for instance, infections in immunocompromised hosts. And the reason they suggest that it should be in collaboration with clinical staff is because you want to draw a balance. The list should not be too inclusive, resulting in excessive notifications, and it should not be too exclusive, ending up causing harm to the patient. The determination of significant and unexpected diagnosis was left at the pathologist's discretion only because of its unusual and unforeseen nature. The fourth guideline was that the communication of the urgent diagnosis should be in a reasonable time frame and if possible within the same day as the diagnosis was made. However, the communication for significant and unexpected diagnosis should be as soon as practical. Again, both were also left at the discretion of the pathologist. The best way of communicating the diagnosis is verbal, and you all may have experienced that for anatomic pathology, because the reports can be very descriptive and wordy, it's easier to talk to the clinician and explain to them the findings and the challenges and sometimes in making the diagnosis. So even though verbal communication is preferred, other reasonable methods of communication could also be used. However, it was suggested that their functionality should be first validated in the system that is being used. And of course, the last guideline was related to documentation. Documentation of communication must include the method that is used, the time and date, and the name of the person to whom the diagnosis was communicated. The requirement to communicate critical value was included in the CAP checklist, the general checklist in 2005. And now in anatomic pathology and cytopathology checklists, they both separately have this as a checklist item. And it is described as significant and unexpected surgical pathology or cytopathology findings. They have used the terminology of findings and not diagnosis. That significantly affects patient care should be determined by pathology department in cooperation with local clinical medical staff. So they have actually left it for each department to determine their own significant or unexpected diagnosis, but of course in collaboration with the clinical staff. They also suggest that there should be adequate documentation, and the requirements and the elements that they have listed are same as that was suggested in the guidelines. To understand the perspective and perceptions of urgent diagnosis, that was the guidelines to see how the perceptions were of the clinical practitioners. Dr. Criteria and Otis at the Bay State Medical Center in Massachusetts, they surveyed their own clinical colleagues, and this included people in the medicine department and surgical department. And they found that there was actually no agreement, as you can see in this bar graph, there was no agreement between pathologists and clinicians on what constituted urgent diagnosis in anatomic pathology. While pathologists felt that only new, unexpected, and malignant diagnosis should be communicated as an urgent diagnosis, the clinical providers felt that any new malignancy should be assumed to be unexpected and should be communicated as an urgent diagnosis to the clinical team. They did not want the pathologist to go into the electronic medical record to figure that out, which many of us often do before we decide it is urgent or unexpected. To then understand, this is now 8 years after the publication of the guidelines, ADASP went back to their members, and their members are all directors of anatomic pathology and surgical pathology, so they're all leaders in the department. They again surveyed them to not now really evaluate the opinion, their personal opinions, but actually to understand how these in their departments had incorporated the guidelines in their policies and what their practice was. In contrast to the previous survey where 25% of the labs did not have a policy, now 5% of the laboratories did not have a policy. So there was a definite improvement. The publication of guidelines did help. And 66% indicated that they had read the CAP and ADSP consensus statement. And 24% of the laboratories said that they did not use the CAP ADSP terminology. That is, they did not make the distinction between the urgent, significant, and unexpected diagnosis, and they actually lumped them in the same category. What is interesting is that these both urgent, significant, and unexpected diagnoses were handled in a similar manner. It is with regards to the method of communication, the time frame of communication, and also documentation. Again, suggesting that there was actually a confusion in understanding the difference between the urgent diagnosis and significant unexpected diagnosis. I did not see much publication outside the United States. However, I came across this paper that was recently published, that is in 2023 in Diagnostic Pathology. This is a study that was conducted in Iran where they actually surveyed 5 different medical laboratories, again, on the same concept to see how critical values were handled in surgical pathology, and they had the same conclusions as the other papers that I just quoted. They suggested that there is no standardization for critical items. There is a need for development of more uniform norms and research in this topic. So clearly there is more work needs to be done. And the biggest challenge that is there and the biggest barrier that I see is that there is a disagreement about what urgent and significant unexpected diagnosis is amongst pathologists, which could be because of lack of understanding of what they are. And second is that there is no agreement between pathologists and clinicians as to what constitutes urgent and significant or unexpected diagnosis. There are a lot of variations in the details of policies as we see it. There is lack of standardization of time requirements for notification. There is confusion sometimes as to who is the responsible person to whom the notification should be made. And in case there is a failed communication, how should be handled and how it should be tracked. And I'm going to now invite Dr. Govind Bhagat to actually tell us what the best practices are in handling these challenges. And thank you very much for listening.
Great. Thank you very much, Dr. Manucha, for bringing us up to speed and giving us a succinct story about the developments, historical developments in this challenging arena area. So what I'm going to do in the next 15 to 20 minutes is be the spokesperson for our group and communicate to you the results of our discussions, which discussed various aspects of communicating diagnoses, from clarifying the definitions all the way down to quality assurance challenges. In terms of the definition, we didn't do much in terms of what was already known. It has been about almost over a decade since the first definitions emerged from the CAP and the Association of Anatomic Pathology and Surgical Pathology Directors consensus document. We felt that if we could clarify some minor issues, maybe we could start the ball rolling on an onward journey to perhaps dissect out what might be the relevant diagnoses that require urgent communications. So as a group, we define urgent diagnoses as a medical condition that constitutes an immediate health risk to the individual and or may require immediate action on the part of the patient-facing physician. As opposed to that, the significant unexpected diagnosis we felt was a medical condition that is not clinically expected, as the words are clarify, or these diagnoses may possibly lead to a change in the clinical management of the patient. Now, urgent and unexpected diagnoses can be put into different bins or situations, depending on the disease processes and the clinical context where they arise and are considered to be important. So over the next couple of slides, I'm going to give you some examples. Now, this is not an all-inclusive or exhaustive list, and nor is it original, because many of these considerations were developed over the past couple of decades, but at least to give you a feel for what kinds of diseases or conditions or situations require urgent diagnoses. And these could be infectious or inflammatory diseases, certain types of malignancies, or situations when one is faced with a change in diagnosis, as well as miscellaneous entities. So again, I'm not going to read through the entire list, but some of the examples of urgent diagnoses the group felt, again, were very similar to what has been described before by others. And these could be other inflammatory immune diseases like vasculitides or renal disorders, transplant-related complications, again, cutaneous or dermal disorders, And at least what I face in my own practice quite frequently is communicating the diagnoses of acute leukemias or aggressive subtypes or high-grade lymphomas. And the examples being acute promyelocytic leukemia, Burkitt lymphoma, or as we've learned over the past decade, other lymphomas referred to as genetic double-hit lymphomas, where you've got translocations of both the MYC gene, oncogene, as well as the BCL2 gene. Now, these are diagnoses that are suspected on morphology, but have to be clarified and confirmed by appropriate cytogenetic and FISH analyses before coming to a definitive diagnosis. Now, regarding the examples of significant unexpected diagnoses, again, you could consider two different buckets, so to speak. One would be situations when you have an unexpected malignancy. Now, these could be malignancies that are incidentally identified when a specimen is removed for non-neoplastic disorder, for example, a hernia sac or an appendix. Or it could be when, rather than a benign neoplasm, you find a malignant neoplasm, for example, a papillary thyroid cancer carcinoma arising in struma ovarii and ovarian tumor. It could also be malignancies found in fluid specimens or carcinomas picked up on pap smears. More frequently, we encounter the situation when there's a change in diagnosis, and this could be a disagreement between the immediate readout of an FNA at the bedside and the final diagnosis, or a disagreement between the frozen section diagnosis and the final diagnosis. And the more challenging areas are when there is an amended report that has to be issued that can impact patient care, which is quite subjective. And so is the concept of significant disagreement or change in diagnosis between the primary pathologist and a consulting pathologist, no matter where the change occurs or the disagreement occurs, at the origination or at the consulting institution. Interestingly, our group also felt that there might be a third category, a combination where the diagnoses might be, or the situations might be both urgent and capture the significant unexpected part of the diagnostic process. And some of the examples for these could be infections, and these could be infections found at sterile sites or when there is evidence of tissue invasion, especially in patients who are immunocompromised. And these could be a whole host of organisms. They could be bacterial infections, fungi, or viruses. And here are listed some of the examples. Another situation which could fulfill both of these definitions would be findings indicative of perforations or fistulas. These could be adipose tissue found in endometrial curettage specimens, hepatocytes in paracentesis fluid, or bile in thoracentesis fluid specimens, amongst other situations. Now, regarding best practice recommendations for the method of notifications, again, as has been found in prior reports and discussions by various pathology societies, no single preferred universal method came out on top. And I don't know whether we're dating the working group who met, but it was felt by many that the phone call perhaps is the best way to communicate these findings. That's the least chance of loss of information, and it also engenders communication and camaraderie. However, it was felt that since our lives are quite busy, that if we don't have the time to pick up the phone or have the time to meet in person or over tumor board, perhaps emails and secure text would do just fine. One of the challenges that everybody seemed to bring up was the issue of who to communicate the results to. As is often the case, there is no clear documentation of the provider on the requisition form, and it is felt by the majority of us that perhaps there should be a required field in the requisition forms which forces the provider to provide this information and would make life easy when it comes to communicating urgent or unexpected diagnoses. And it was also felt that there were significant consistent problems with particular groups. Perhaps one should escalate this issue to the practice of hospital leadership and get buy-in from them to figure out solutions to this problem. Another area where we felt time was ripe to harness technology was for the deficient and timely communication barrier that was brought up earlier. We've come a long way over the past decade, and especially after COVID, There have been plenty of developments in the field of artificial intelligence and technological innovations where some of the lower-hanging fruit would be automatic flagging of these diagnoses or these situations in the laboratory information systems or the electronic medical records. It was felt by many that we should encourage the manufacturers or vendors to prioritize the build and develop the functionality for closing the loop between the diagnostician and the provider acknowledging the receipt of results. And as we just learned from Dr. Gupta, that there are conversations that have already begun between pathology societies and some of the vendors, including Epic. And it turns out that there is a lot of interest in developing such solutions. Now, use of artificial intelligence algorithms is the new kid on the block, where everything is AI nowadays. And it's interesting to see that apart from the developments that have mostly been at the forefront regarding generating diagnostic labels, it has been felt recently to perhaps now to focus our attention on basically unleashing these algorithms on the diagnostic journey, so-called wayfinding, or the whole process from the first encounter of the patient to the end result being a very complicated scenario where we've made some inroads, for example, the concepts of diagnostic management teams or disease management teams and decision support systems, but perhaps there's more work to be done to simplify life and make this a reality. Now, in terms of the policy requirements, I don't think we've added much to what has already been spoken before. It was felt that we should definitely enforce a policy, and this would be an institutional or a practice enforcing the policy for communicating urgent and significant unexpected diagnoses. And these policies should include what has been suggested before, which are the definitions. So they're clear and succinct, examples of diagnoses which are germane or peculiar to the practice setting, timeframes for communicating the findings, and the documentation requirements for the notification of diagnoses. And with the growing subspecialization in our field, it was felt that perhaps the consultation should be between subspecialists and the relevant clinical teams to come up with what would be the criterion and what would be the findings or diagnoses that would be important to the clinical team as well as the pathologist taking care of patients at that particular location. Now, in terms of timelines for notification, we still have challenges. As was mentioned before, there are instances where both urgent and significant unexpected diagnoses were thought to be communicated in real time within 24 hours and preferably on the day of diagnosis. Now, this is a challenge depending on how the practices are structured, but perhaps we could consider urgent and perhaps the urgent and the significant unexpected combo diagnoses to stick to these tighter time limits, and perhaps the other significant unexpected diagnoses which don't have an urgent component to them could be delayed and dealt with as the diagnostic process proceeds. Now, regarding the documentation of notification, the best practice recommendation that the group came up with was the simplest one, where most of us are very familiar with, which is adding notifications in the pathology report itself, either in the main report or as an addendum. And this would help capture many of the documentation requirements, such as the date and time, the person notifying, as well as the clinical colleagues notified, and the findings that have been communicated, which are already in the pathology report. Since we do have newer functionalities in the electronic medical record systems, many felt that the laboratory information systems and the Epic chat features and Epic and related EMRs could also be used. However, here, one has to be careful in making sure that one communicates the findings, which will not automatically carry through, along with other features in terms of the person being notified along with traceable identifiers. Quality assurance, I think, is the biggest challenge. Again, relying and awaiting newer technology breakthroughs to come along and functionalities to be included in our laboratory information systems. It behooves the departments to start at least thinking, if not designing methods, to track cases of urgent and significant unexpected diagnoses, and trying to figure out ways on how to even capture the documentation of what was communicated to get a really granular details about the process. Now, again, information technology solutions can assist. Now, what are they? Still in their infancy. I think natural language-based algorithms and other foundation models can be helpful. And I think if one can generate lists and catalog these cases and bring them to the attention of their pathologists on a periodic basis, at least annually, one would really go far in figuring out further refinements to this process. So before I finish, I would like to say a big thank you to all the panel members who are listed on this slide. None of this would have come about without their input and countless hours spent over multiple virtual meetings. And also thank you to all of you listening in who have taken the time out from your busy schedules to really listen and see and learn and hear about where we are regarding reporting of urgent and significant unexpected diagnoses. So with the time permitting, I think we have some time, so we're open to any questions that you might have. Thank you very much.
Thank you very much. Thank you, Dr. Bhagat and Dr. Manucha, for the fantastic, great presentation. So we have some questions actually in Q&A section, and the questions are still popping up. So the first question we received was regarding the prelim versus final. At what point do you communicate urgent findings that yet to be confirmed definitely? At the time it is suspected or after confirmation of your suspicion?
I can go ahead and give an answer for this. So personally, I communicate with my clinicians when I start suspecting a diagnosis, especially if I think it's urgent or it is going to be, it's of an unexpected nature. And again, that I think helps. Making a phone call really helps because you're actually discussing and describing your findings, and you're also giving them a differential diagnosis. You're letting them know that you're getting an ancillary testing done. And also, if it is going to change your diagnosis from some low grade or high grade, I think it's really pertinent that you pick up the phone and talk to your clinical team. Well, you could also make a second call after the diagnosis has been confirmed. But I personally think it's best to pick up the phone and talk to them when you start suspecting something that you feel is of urgent or unexpected nature. Dr. Bhagat, do you have any other thoughts?
I agree. I mean, at the very least, as we discussed even in our group, I think a lot of these ideas are supposedly common sense. Now, it does become a challenge depending on the practice setting. If you were in a huge commercial reference lab setting or a smaller community hospital setting or an academic institute in terms of the expectations of communicating these diagnoses. But I do think there's something to be said about professionalism, where if we have the time, I think it behooves us to make the time, not only will it enhance patient care and the diagnostic process, but also increase the camaraderie and our sort of bonding with our clinical colleagues and understanding each other. I think this is very essential.
I'd like to add one thing. I think it's easier for us because we're in academic centers and we have subspecialty sign out. So most of our physicians are on our speed dials, and it's easy for us to text and pick up the phone and talk to them. But I did see a question where somebody's thought about LabCorp or Quest, where they do not have that easy access to physicians to pick up the phone and talk. And I think these are such big entities and organizations. I'm sure they can come up with some system where they can actually flag through their lab information system that they use, stuff that Dr. Bhagat was talking about. I mean, this is exactly where you want to harness technology, where they feel there is something urgent, they can flag it, and their clinical provider, whoever has sent the specimen, gets an alert immediately. That's significant. I think I do understand that picking up the phone and talking to them verbally is a challenge in those systems.
Yeah, thank you. Thank you both. I have another question, actually. This is regarding the IT solutions, Dr. Bhagat, you were talking about. Would you consider having an autofact set up as sufficient for communication of results?
Well, this gets down to the heart of the problem, where I think a lot of smarter people, way smarter than me, are trying to address this and have been trying to address this through different societies like this Association of Pathology Informatics, American Medical Association, and others, where it's been figured out that simply transmitting a message is not sufficient because we don't know who's reading these messages at the other end. On the other side, if you were to transmit the message back to the ordering physician, it's not clear whether the entire clinical care team is being notified of the urgent or unexpected diagnoses, and there might be other team members who also would benefit from this information. So I think time is ripe to come up with dashboards and flags like we have for clinical pathology laboratory medicine issues that would be visible to everybody who's accessing the patient record. And this would really enhance the diagnostic process and making sure that we reduce errors. So I think this is, in my opinion, our low-hanging fruits, but I can imagine that developing technologies is easier said than done. But this is where our IT colleagues can come in and develop solutions to simplify this process. Again, saving time on top of making sure that all the relevant players are getting access to this information.
Thank you. Thank you very much. We have another question. The question is, if the prostate biopsy in the setting of high PSA shows malignancy, does it consider expected significant diagnosis? Does it need notification?
I can take that question. I do GU pathology, and I do not call up my surgeon every time I see a malignancy in an elevated PSA biopsy. It's expected. I don't think he'll be happy if I start calling him for every malignancy that I see in prostate biopsies. It's an expected diagnosis, and I wouldn't pick up the phone or call them up. And I don't think the expectation is there from my surgeon either. Again, it also helps if you talk to him and he says, you know what, every time you have a diagnosis of adenocarcinoma and prostate, call me. Unlikely that they will do that. So I really don't think that we have to do it for this kind of diagnostic.
Thank you. Thank you, Dr. Manocha, for answering the question. We do have a question regarding the policy. How do your institution audit adherence to critical value communication policy in anatomic pathology? What measures are tracked? So can we make sure that we are complying to the policy? What are the audit measures to be put in place?
Well, this is what I mentioned in the last slide in quality assurance, that this is the biggest challenge we face. I think many practices do keep track of amended reports. So at least that part, wherever there's a significant discrepancy between the original diagnosis and the consultant's diagnosis, are kept track of. That's definitely a QA metric that we monitor at my institution. We also have the list of diagnoses, and we try to circulate this and make people aware of these concepts. And regular QA meetings, when we discuss different subspecialties, we often have discussions about how the communication process is working and what can be done to enhance it. I frankly don't have a solution. As I mentioned, this is something that is hard to track in terms of who communicated and how. If we can come up with tracking these cases on a more regular basis, for example, screening addenda reports, or making sure that whoever is participating in these, communicating these unexpected or urgent diagnoses, keep a track or a log, or can go in and automatically flag these in their systems, these perhaps might be ways that the department could then go back and take a look. But this is mostly an honor system. I think we still are waiting for an objective, automated solution which could get all this information and not take too much time away from pathologists. Again, I mean, I'm just waving my hands. I'm trying to come up with creative ways that this problem might be solved, but I really don't have a simple solution to this problem.
Yeah, and I'd like to add to that. I think anytime there is a lapse in communication, it is going to come and stare at us. You really can't escape it. You will receive a call from the clinical provider. It's going to go either to the director of AP or to the chair. And any such event that happens, either rather than shoving it under the carpet, I think it is something that should be discussed with the pathologist so that you become aware and learn from your not really mistakes, but things that are missed. Because then you also understand that this is the expectation from your clinical team, and this is something that you should communicate. I did come across one question where there was, what is the timeline for reporting diagnosis? Is it 24 hours from collection or 24 hours from case sign out? I think it is not necessarily sign out. The moment you make that impression, the moment you make that morphologic impression, you look at the slide and you think this is not right, I think that is where the time starts. Again, like Dr. Bhagat said, it's an honor system. I put myself on that 24-hour time limit, and I make sure that my clinician knows about it.
And one more question, Dr. Manucha, might be relevant to your practice. Would endometrioid carcinoma in EMB performed for postmenopausal bleeding be considered an unexpected diagnosis?
Well, if it is for postmenopausal bleeding and a woman who is older than is in postmenopausal age, and there's an endometrial thickness, I think the clinicians are already expecting and are they open to receiving a diagnosis of malignancy. First, it's a new malignancy, though. Is it unexpected? I don't think so. So yes, there should be a notification, there should be an alert, but I don't think I would classify it as an absolutely urgent, immediate notification diagnosis.
Thank you. We have a couple of more questions. I think we have time. We can take a couple of more questions. The question is a previously communicated frozen section diagnosis considered sufficient for communication of an urgent or unexpected result, like a frozen section result?
Well, I can take a stab at that. So if the frozen section, if I get it right, if the frozen section diagnosis has got enough information, or the pathologist gets enough information from the frozen section to communicate this diagnosis, then of course. And if this is communicated, and obviously this result will also show up in the patient's pathology report. The challenge is when there are issues where the frozen section diagnosis differs from the permanent record. There, of course, one has to be careful that if there's a change, that is documented and reported in the report, and the reasons explained as to why there is a change in the diagnosis. If the short answer is if the frozen section allows you to come up and state an urgent diagnosis, by all means.
Sounds good. Thank you. This question actually came up early. I missed this. So if you're unable to reach a physician directly, is it acceptable to give the results to like a nurse practitioner or a nursing assistant or answering services if the name and the title of the person is documented?
Well, in my practice and in our opinions, as we discussed as a group, it was felt that as long as the communication has taken place and there's a way to trace the communication, and if somebody in the patient's care team has been notified, that could be sufficient. It is a challenge sometimes to, as we mentioned, to find who the individual is who has submitted the specimen or who's directly responsible for the patient, whether it's not mentioned on the requisition form, or the situation commonly arises in the emergency department where the person who's responsible for the patient has moved on, the shift is over, and it's hard to trace the next person who's taking over, and there's obviously a danger in a lapse in communication. So those are the challenging issues that we all felt still require a lot of work. But outside that setting, as long as you're using an electronic medical record system like Epic, it is felt that Epic Chat or other ways of communicating these diagnoses, as far as your diagnosis is mentioned, the timestamp is there, and the person who the result was communicated to is mentioned, that would be the second best scenario in lieu of not being able to reach the provider themselves.
Yeah, I agree. I think if the diagnosis is really urgent and it is that significant, then you have to sometimes you use multiple modes of communication. Personally, if I left that notification on an answering machine or an answering services, and I know that it is not a physician or part of the clinical team, I would be nervous, and I'll make sure that I use other methods of communication as well. So I would make sure I'll try the phone call maybe a couple of times. I'll put my resident on the prowl, but I think it is best if you can actually communicate to at least one of the members who takes responsibility and ownership in the care of the patient.
And if I might add, we use emails way more often as a second line after a phone call, because there, at least, if you don't get a response, one can try another time, perhaps after a couple of hours or the next day, and hopefully after a couple of attempts, be able to track down the physician, because you like to hear that the message has been received, rather than simply going into a void and not being sure whether the communication has really occurred.
Yeah, and one of the challenges I see is there is one of our very busy head and neck surgeons. I send emails to her. I know she receives it, she reads it, she never responds. So I never know that she read it or not. But every time I see her in the tumor board, she's like, yeah, I got it. So I know her now, I know her nature. So I'm fine when I send her an email. And even if she doesn't respond, I know she read it. So I think understanding your clinical team really makes a difference. So the more you pick up the phone, the more you talk, the more you interact, the more you collaborate, the better the communication is and better the patient care and outcome is.
Thank you so much. I think we are at the top of our hour. So let's move on to the next slide and wrap it up. So thank you, everyone. Thank you, first of all, Dr. Manucha and Dr. Bhagat for an outstanding presentation. And thank you all of you for attending the webinar today. There will be a very short survey. Your input will inform our future educational initiatives. One more thing, for the CME and CMLE credit for this event, you can scan this QR code, which you see on your screen, or the instructions will be emailed to your email address you provided at the time of registration. The slides of this webinar will be shared after this presentation, and the recording of this event. It will be accessible through the course link by July 30th. And another question actually which came up in the Q&A, how we can access these recommendations, this list of examples. Actually, we are presenting recommendations and this project at ASCP annual meeting, which is in September in Chicago. Please, if you have not registered, please go ahead and register to the ASCP annual meeting. And also, we will publish these recommendations in a form of a resource guide or a playbook, and that will be hopefully available by the end of August to everyone. It can be downloaded for free actually at the ASCP website. So these are the things which are lined up and underway for you. So with that, again, thank you very much, everyone, and our presenters and our funder, Gordon and Betty Moore Foundation. We appreciate you all. Have a great day. Thank you.
Thank you. Thank you very much. Bye-bye.
Thank you.